Oof.
And the reason I want you to put it away is that you have to pay attention to what we are doing in this class. That way, when it's time for you to do the exam, you will have an idea of what to do, because you will not want to lose out both ways. Okay, so my advice to everybody, if you have an exam, the best way to study for an exam is do it a little at a time as you learn the material, and not to stay up all night to cram the content and then expect that you go to that exam hall, you'll be able to be functional. It does not happen that way. If you spend the whole night up, what you are doing is depriving your brain, and in the morning, you go to that exam, your brain is in spasm. The little that you know will evaporate. So do yourself a favor. Have a good night meal, dinner, rest your brain, sleep well, and wake up fresh to go to the exam. Okay? Please don't wait for last minute. Last minute is no, but I know people will, stress, the adrenaline will kick in, and then you'll be able to do the things you do. But over time, they are not doing yourself a favor. Okay, so our business today is the GI and GU system. And as usual, we'll begin with highlighting some of the differences in the anatomical differences between the adults and children. And then we'll have to, point out some of the common conditions that we see in children in the GI and GU. And then we'll, once we identify those conditions, we'll put the medical treatment and the nursing intervention so that we'll be able to plan a care, so that when we get those patients in the unit, we'll be able to care for them. So, having said that, I will begin with the differences in the GI tract. So the first part of the lecture will be the GI tract, and then we'll end up with the GU. So, as we know, and as we have been highlighted from the beginning, the GI tract in children, all structures are immature, and as they grow, and as they, maturity will kick in with development. And again, the GI tract we know starts from the mouth. So what are other structures that is part of the GI tract? Okay. 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 All right. So all those areas they belong to the GI tract, and these are the areas that we kind of zero in right now. So in children, swallowing is involuntary for them until age 6 weeks. And in infancy, they have minimal saliva. But you will say, oh yeah, but they drool a lot. Yes. But their saliva is minimal. Their stomach lies transversely and slightly horizontal. When you look at the capacity of the stomach, is just very small. And that's one of the reasons why we cannot overfeed them. We start with small amount and and then we increment it as the child grows and as the child is able to tolerate the feeding. Because if we attempt to overfeed that stomach over the capacity, it will put tension on the sphincters that separate the chest wall and the stomach. And that's why sometimes you see them having what we sometimes refer to in layman terms as a wet walk, because that stomach, that sphincter is relaxed, and this is just fear of immaturity. But as they grow, it's just, it disappears, but sometimes it persists even into adulthood. And that's when you will see that somebody has a gastric esophageal reflux disease, even in adults. Another important thing you need to know is that in children, the hydrochloric acid content in the stomach is less, and this will have an implication when they start vomiting. So they have little hydrochloric acid. On top of that, they are vomiting, further depleting the hydrochloric acid content in their body and in their stomach and in their body, and that can put them into metabolic alkalosis. Okay. Other things that is happening in the children will be the peristalsis, the movement of food from the mouth through their GI tract. That movement and churning of food tends to be faster in children. No wonder they get so hungry easily. Okay? So, and because of that, their food will remain in their stomach just for a short period. So it just goes in fat. And then coupled with their increase in metabolism, so it's just turning away. Again, in the children, you have the increase in metabolism and all that can also lead to, if they have a fever or diarrhea or vomiting, anything that causes that, coupled with the increase in peristalsis, that can really impact on the children. Other things that can happen will include their body fluid. They have a large amount of fluid in greater proportion than the adults. And when we look at the kidneys, you'll notice that the kidneys are immature too, and therefore they are not concentrating urine. So, having said all this, we know that in children, any slight fluid loss, because most of their body fluid is extracellular. You will recall that we have intracellular and extracellular. And in both the intra and extracellular fluid, we have electrolytes that are present in those fluids. For example, in the intracellular fluid, we have the potassium, we have the magnesium, we have the phosphorus, and we have the sulfur, all within the cell. and that will be intracellular fluid. And you will see the implication of this when we go to dehydration or anything that will cause that fluid shift from intra to extra by virtue of osmotic pressure. So you see that implication of that when we do that. On the extracellular fluid, you have sodium and chloride. You also have your bicarbonate in that extracellular fluid. And this particular extracellular fluid will comprise of the plasma as well. And these are the ones that circulate in the system that transport nutrients to the body cells and to the body organs. So it's important that you understand which fluid it's where. That way you will appreciate that fact when we do anything that will have a disruption of that fluid level, so that you will know what could be the possible problem, and you appreciate why it is a priority in pediatrics to replace fluid loss and to maintain adequate fluid level. Okay. So, from my notes, you have those that I don't want to go over it again. The liver function is immature as well. So, with all these immaturity going on, when we get to see a patient with GI problem, and now this is any kind of GI problem now, we're just doing an overview of GI assessment that we will do. And then when we get to the individual conditions, we kind of zero in what we're looking for those conditions. So as we did with respiratory care, with the GI, your number one thing you would like to know would be get a history from the caregiver and or from the child if the child is old enough. So what will be part of it? What will be some of the things that you will ask them for? You know, drawing that knowledge from your anatomy and physiology or your pathophysiology that you did, what kind of things will you be asking the patient, asking for in the focused GI assessment? Yes.
Last bowel movement.
Last bowel movement, yes. Eating habits, yes. Any others? Yes. Fluid intake, yes. Okay. What else?
Pain or distension in your abdomen.
If the abdomen is distended, you can visualize that. Okay, yes. See that, and also when you do your physical exam, you can palpate, and but there are conditions you do not palpate, you get to those places. What other things would you like to know? Yes.
Do you have any like past surgeries,
Any past surgeries? Okay. So you would like to know all that. So now you will direct your priority questions based on the first, because you ask the mom or the child the first question, what is the chief complaint? Based on that chief complaint, then now you kind of update your question quickly to what you want to know. So you would like to also As you gather the history, and then you do that, and you'll be able to plan your care. Part of your care, you know you have to do a vital signs, you have to maintain your fluid and electrolyte balance. And that will be part of your intake and output as well. As part of your vitals, also you need to weigh the patient, height and weight. For us in pediatrics, we love weight. We love height and weight in the sense that we can use that to calculate the body surface area, but for us, we are kind of leaving the body surface area calculation aside. Not that it's not important, it is very important, and when you go to a higher level, you will automatically switch to that body surface area calculation. But for the most part, we'll use the weight to do all calculations, both the medication, both the food, both of everything. So it is important that you get that weight. And then you do your assessment, physical assessment of the abdomen. And also you would like to, if you have stool, you may want to check for blood in that stool, so that will be the stool for occult blood or chemocals. Other things that we can do would be we'll do a CBC, erythrocyte sedimentation rate and electrolyte, because we like to know with the CBC what are we looking for? Yes, white blood cells, we want to know white blood cells where there's any evidence of increase in the neutrophils or leukocytes that will tell us that there may be some inflammation here. Or we look at the hemoglobin hematocrit and it's slow. Maybe this child is bleeding somewhere. Okay? So you look at anything you look at, it will tell you something. You're looking at the liver enzyme, whether there's a problem with the liver enzyme with the child is jaundice or anything like that. If you look at the stool, of course, we're looking at the stool for anything, especially for our some of the conditions in GI is characterized by the stool. It could be constipated stool, there may be blood in that stool, there may be a lot of fatty tissues in that stool, so you will know in the stool. And then we look at whether there are any parasites in the stool. In third world countries, that one is number one problem that they have all the time. Okay. And then they can do the GI series, colonoscopy and all that to see, serum enemas and all that to see. But please note, if you are giving an enema in the child, we do not want tap water enema, because that will put them at risk for water intoxication. We would rather do the small pediatric enema. Please, just quiet. So, having identified all those conditions, things that we'll be asking for, some of those GI conditions in general, some of them you will notice that the child, failure to thrive, and that may be just one singular thing that the mom will tell you, or you will notice that because you are seeing this child, the child will come to the clinic, you weigh the child this time, do the measurement and put it on that growth graph, and then when they come again, the child is still the same weight. There is no difference. And you did your weight the same exact where you did it the last time. There is no increase, there is no, and then you look at the child and something is not right here. Child is not growing. Mom can complain of that also. Or child is spitting up. Or child has nausea, diarrhea, or maybe constipation, or maybe abdominal pain. And all these, and then when you listen, the bowel sound may be hypo or hyper, reactive or even absent bowel sound. Absent bowel sound, you may hypo or absent may come in obstruction. Sometimes hyperactive bowel sound, will be when there is uh, um, you know, like in the cases of diarrhea, you may see hyperactive bowel sounds. Or then again, our old friend fever will always come in place anytime. So, any questions on those symptoms in general, then before we kind of break it up to each of the conditions? Okay, so the first thing I would like to look at here will be the condition, dehydration. Dehydration to us is a very important concept that we need to know, to identify it promptly, and to be able to correct it right away. Anytime there is total intake that is less than output, regardless of any of the cause of it, a child can get dehydrated from vomiting or from diarrhea, or just by that insensitive fluid loss, meaning from sweating. Remember, they do have very high metabolic rate. Okay, so 1 degree rise in temperature can result in significant fluid loss in a child. And again, another thing that makes it faster will be, remember, the bulk of the fluid is in the extracellular. So they are losing all their extracellular fluid, the sodium, the chloride, they're all going. And with that happening, there is fluid will now shift from the intracellular, from the cells, to compensate for the one in the extracellular. Remember, the extracellular fluid is the one that goes through the tissue that supplies the nutrient, okay, and it's part of that plasma content. So now you have less of that. That is the problem. So we can classify dehydration as the amount of fluid that is lost. We'll put it as mild, moderate, or severe. A mild fluid loss, we will say it's about 5% of total fluid loss. For the moderate one, we're looking at about 10%, and anything over 15% is very severe. That's that, and you must take care of that child, otherwise trouble. Okay. So for types of diarrhea, we're looking at the isotonic dehydration, types of dehydration, not diarrhea, would be, so now we classify that diarrhea, or we are identifying based on the relationship between the fluid and the electrolyte. So that's what we will use to gauge the dehydration. So when it's isotonic, and that is when the fluid loss is equal to the electrolyte loss. Both of them are lost in equal proportion. And this is the most common one that you will see. And then we look at the hypotonic one. And this could be a condition whereby you have more fluid loss than you have more electrolyte loss. Hypo, you have more electrolyte than you have more fluid. And then the hypertonic, you have so much water loss leaving the fluid very concentrated. And this one is the most dangerous one. So looking at these signs and symptoms that how they will present, you have a similar chart on your book, but we'll look at this one. So for the level of dehydration, you look at the pulse rate, so you try to identify, put them in perspective where they belong. For the mild one, you look at you do your assessment. Heart rate, pulse rate is still within normal limits. Blood pressure is still within normal limits. Child is still acting the way they, it's really not too much. Mucous membrane, you may still notice a little bit slightly changing. But when you look at the urine specific gravity, you may start seeing a little bit of change. What is the normal specific gravity of urine? 10 what? What is it? 10, 10, 10, 15? 10, 10 to 10, 15. Okay. So, in that mild one, the child's body will kind of compensate. And these are the ones that you replace the fluid loss, with isotonic solution. So what solution will be referred to as isotonic? Normal saline, which other one? There's another one. Lactate. Lactate. So you can replace with that. For us, oral one will be the Pedialyte. That will be good stuff. Yes. Now, for the moderate one, you do your vital signs. The pulse rate is slightly high because at this time the child is having some little bit of tachycardia. The body is still compensating. But the blood pressure maybe kind of, a little bit orthostatic, hypo a little bit. Then at that particular time you start noticing some slight changes in the child's behavior, which will be for us, that child will become irritable. Stop refusing to do and just acting, crying and being cranky. Mom will say, oh, my child is so cranky, not try to console the child that it's not doing anything for me, just crying and just very restless. Mucous membrane at this point, you look at it, it's very dry. The skin looks dry also. The child is irritable, crying, but there is not much tears, production at that point. And then there is more concentration of child urine. Okay? Child may have urine output, but it's diminished urine output. That's the oliguria, diminished urine output. But when you get to the severe one, child is in shock. Child is really have tachycardia, and that tachycardia, if nothing is done, it will reverse to bradycardia, and by the time it reverses to bradycardia, you are losing the child. So the early time you notice your early tachycardia, please do something for that baby, because if you wait for that to flip to bradycardia, then it may be too late for that child. Okay, because that child is going into shock. That child may become very lethargic and very into shock at that time. The skin is very dry, like an old lady skin. But when you look at the skin, comparing it with that of the older adult, their dry and their inelastic skin is normal for that age group, but not normal for a child. Okay? So when you start seeing something you should see in an older elderly person, in a child in terms of the skin, and you start seeing it in a child, that is not right. Other things you can see, if the child still has the fontanelle, you see that it's depressed. Okay. And there may be no urine at all. And then you ask the mom, oh, what time when did the child boil? No time. Get the very or maybe I just changed one diaper, like yesterday morning, and now we're talking about today, like something is wrong with that child. Yes.
Hold on.
Oh, you just written it, okay.
Take the rest.
Okay. So, what do we do? Well, we do our labs to find out what is going on. We'll pay particular attention to our friends, the sodium and potassium here. And also the creatinine and BUN level, because we use this creatinine and BUN to gauge the health of the kidney. Okay? And then we do our assessment, we maintain our hydration status. Note that the weight is the most important assessment you will do that will determine the total body fluid loss. Okay? In infants and younger adults, infants and younger children, weight is the most important thing that you will use to gauge that fluid loss. So our aim would be to replace the fluid volume and prevent progression into hypovolemia or hypovolemic shock. So again, for the mild and moderate, we just give oral rehydration, and we log weight in pediatrics, so we do it by weight. Please note that tap water, sterile water, or undiluted juice is not a good source of electrolyte replacement in the face of dehydration, any form of dehydration. Pedialyte is fine. We can teach the parents also to make their own fluids. Usually they are solution of salt and water. Okay. In severe dehydration, we have to do IV replacement. And usually IV is replaced according to the body weight. But please note that we will start that replacement fluid, first of all, by giving the isotonic solution. And then until the child voids, until you see a urine output, you cannot add potassium, because the potassium normally lives intracellular. And in the face of severe dehydration, potassium is now will go to take the place of sodium that has been lost with those fluids. And being in the extracellular fluid, at that point, that increase in potassium is circulating in the tissues, including the renal tubules, and that can cause necrosis in the tissue. And then you come again to add potassium also in that fluid. Remember, it's the extracellular fluid that goes to the tissues to give the nourishment, not the intracellular. So now you have excess potassium on that extracellular fluid, and then now you are giving additional to increase that, that child can get into cardiac arrest for that hyperkalemia. You can damage the child's kidney for good, and the child will end up with end-stage renal disease. So, you start your replacement without potassium, and once the fluid shifts back and the electrolyte potassium shifts back to its normal place, being in the intracellular space, then you can introduce the potassium to correct the deficit. And this one is a must-know concept, because that will be the singular assessment that you have to do, non-invasive assessment you need to do on that patient, is just to ask that question. Did the child boil? And if mom says yes, you need to see that wet diaper, or you need to see that urine in that cup before you add your potassium. So how do we calculate fluid replacement? Again, we say we use the body surface area, which I'm not bothering you with, but the one with the weight, you need to know this. Simple formula. For the first 10 kilograms of body weight, you replace by 100 milliliters per hour. And then, not per hour, 100 milliliters per kilogram body weight for the first 10. And then if the child weighs more than 10 kilograms, the second kilograms up to 20, you replace with 50 milliliters per kilogram. And if for any reason that child is over 20 kilograms, the remainder of the excess weight above 20, regardless of whatever it is, you replace at the rate of 20 milliliters per kilogram. And you would like to do that, get the calculation, and then you will divide it in over 24, divided by 24 to get your hourly rate. So that the first numbers that we gave was for the total replacement over 24 hours. Now, for the urine output, we will expect to see at least 1 to 2 milliliters per kilogram per hour. That's our expectation. That's how we are gauging what we are giving, whether it's really effective or not. Okay, so that's what we'll be gauging. So now, looking at the quick replacement fluid, this child weighs 20 kilograms. By what we just said, the formula, so the first 10 kilograms will give him 1,000 ml, the second one will give him 500, and the other remainder of 12 kilograms, we're giving 240 ml because this child weighs 32. And this will give us 1740 in 24 hours. And if we need to find our hourly rate, we just divide it by 24 and get the hourly rate. So what is the hourly rate on this child? Anybody, punch the numbers. You have calculators. Punch it. What? 32.5. 72.5. 1740 divided by 24. So, the example number 2, the child weighs only 8.5 kilograms. Again, by that calculation, we're just doing our first 10 kilograms. We'll just multiply that by 100 and we get our 850 ml. Again, over 24 hours. And then our child weighs 14 kilograms. Then again, we're doing the same thing. First 10, we are running at 100. The second 10, we're doing at 50. So we get our total amount. This concept you must know, okay, because I will ask it, and you will see it probably in your other exam, not necessarily my exam, but for the purposes of this class, you get it in your unit exam and you get it in your final. So you have to kind of know that calculation. And if you are in the clinical area, we will ask you to check the maintenance, the ID that you are running, whether it's appropriate for the child, because you're basing everything on the child's grade. So you will have to, if you don't calculate it for us in the clinical, you will not use it in the exam. Guaranteed. So, another condition we have is any questions so far before we move on? Questions? So other conditions will be diarrhea, which is increase in frequency and decrease consistency of the stool. There is more stool, but there is nothing in it. So sometimes it will be literally fluid. It can be acute or chronic. Acute, or it could be acute infection, diarrhea, which can kill children. In fact, we are seeing it here and also more in the developing countries, especially where they have, poor water supply. Okay. It could be from bacteria, it could be from a virus, it could be a parasite. Sometimes you have antibiotic-induced diarrhea. A child has upper respiratory tract infection, and you give that child the antibiotics, the child will develop diarrhea. Okay? So again, in all these incidences or these conditions that will lose fluid and electrolytes, our priority management will be to replace that fluid and electrolytes. We'd like to replace it, and then we'll go back to the fluid calculation and everything that we've done, because we would like to prevent diarrhea from progressing. Okay? So, prevention of diarrhea, of course, will be personal hygiene, simple hand washing. You can go to a daycare center and there is outbreak of diarrhea. Of course, we want to check out what kind of hygiene they are doing. Simply teaching them or emphasizing good hand washing their hands minimize that spread of infection. Clean water and careful preparation of food without contaminating that food, or avoiding eating of raw or contaminated food can also be part of the prevention. Constipation is another thing that happens, which will be the opposite of diarrhea. In this instance, there is alteration in the frequency. The stomach is hard and difficult to pass. Some kids will have chronic diarrhea, constipation. Some will be with no cause, but they just have constipation. And those are the ones that we refer to as functional or idiopathic constipation. Yes, you are raising your hand? No? So, in all and all, the constipation, what you would like to have is to have a bowel regimen that would help to regulate the stool. You will have to kind of promote increasing fluid intake, increase the fiber. In children, we love mineral oil, and we love mineral in children, so we use both. And sometimes they will give Seneca at night.
Mineral oil, doesn't that act as a lubricant instead of softening? Is that for softening the stools or
Yeah,
the
they
package of
they
the?
can put it, you can use that. No, just plain vanilla oil. Some will other by the more, yeah, then we can use, we'll use that. We'll use mineral, mineral oil, um, olive, food softener, because we would like to have like a regular, maintain a regimen of the bowel prep. Now, in some instances, they may have to give sleep element. Yeah.
So you do it in like the mineral oil in the hospital once they go home.
They can do that. So, you are doing OB right now. One of the things that you will, conditions that can cause that constipation will include if the child does not pass meconium, or with our friends cystic fibrosis they have because of that um, big secretions and decrease in mortality of that, that can lead to a meconium clot, or in the disease, Hirschsprung disease or hypothyroidism can cause that. So again, these are some of the ones that can happen also with infants. Adult child in a school, changing in environment can result in stress in the classroom, stress in school, or family disruption, especially when mommy and daddy having their quarrel and then, so it's like when two elephants fight, the grass will suffer. So now the kids are suffering for that. And with that stress, they can take it, and that stress can manifest as anything. It could be as constipation, it could be as abdominal pain, it could be as sleeplessness, it could be insomnia, it could be anything. The way the child will manifest as that stress. Again, we want to promote that habit and use food supplements and what that we related before. Now, vomiting is another thing that won't be of a concern. Again, this one we are using fluid and electrolyte. Again, what we think thing is to prevent dehydration and correct that fluid loss. Like when we define dehydration, we said anything that can cause fluid loss regardless of whatever that is. Okay, so our strategy to replace that fluid. Now, moving on to some that is part of immaturity and also could be some problem, and that would be the gastroesophageal reflux. By virtue that cardiac sphincter, that the sphincter that separates the esophagus from the stomach is not. When the child feeds, the sphincter is not closing, adequately to prevent content from the stomach from going up to the esophagus. So when that happens, you attempt to burp the child will have a little bit of wet burp, but sometimes that condition will persist, and that's what you refer to as gastroesophageal reflux. And you put gastroesophageal reflux disease when you're looking at older adults and older children. So it is abnormal when that happens. Okay? And how do we deal with it? How do we know? Well, we notice that that child is vomiting, and mom will also tell you by that history that you get from her. And the diagnostic workup we need to do, we can do that esophageal pH, to put the probe and measure the pH level. In the esophagus, there should not be acid in that. Acid belongs in the stomach. So if you put that pH probe and it is acidic, which means that the stomach content is transferring to the esophagus. And that can have an implication because it can start irritating the esophagus because the acid does not belong there initially. Okay. Again, you can see they can do their upper GI series, or they can do their CBC relief and all that. From that irritation of the esophagus, the child can start losing blood from there. So how do we treat it? Well, we want to give small frequent feeding because we said that we do not want to overstop the child. So we give small frequent feeding. And then we can also give medications like Pepsi, Tagamet, to decrease the acid production and stabilize the pH. Okay? And then they can do, if that does not work, then they will do a surgical procedure by, kind of tightening the sphincter, and that is called the fundoplication. Once fundoplication is done, this child will not be able to pop again because the sphincter is now sewn together. It does not have that natural ability to open, with increased pressure, but it's to let the air out when they want to pop. So now this child will have to let their air out through the other end. Or if the child has a G tube, then you have to vent the G tube. Okay. So again, we would like to teach the parents, feeding technique, positioning that child, head of bed up, avoid propping the child, positioning the child to the right side. We also want to maintain airway potency. What will be our concern here with the persistent reflux? What is the priority concern here? Aspiration. Aspiration will be number one thing you are worried about, okay, as you plan for this child, and then every other thing will follow behind that aspiration. Okay? Teaching the parents what to do and how to care for that child. Any questions? All right. So another thing will be the acute appendicitis, and this is just inflammation of that appendix, and the child will present with that once that is inflamed. Child will complain of abdominal pain to the right side. And most of the time it's just at the center of the umbilical here, and then it will refer to the side. And that's called the McBurney point. That abdominal pain will be the first thing, and then it can be followed by nausea, vomiting. Like the patient we had yesterday was had pain, pain and vomiting. And then, yes, other conditions can present as pain and vomiting. Viral infection or upset stomach can do that. So the child was, well, the thought it was just plain viral infection. But by the time the parents sought medical help, the appendix had already ruptured. So, to diagnose the appendix, we need to do either a CT scan or an ultrasound, and you see the inflamed appendix. Once the child is still complaining of that pain, and you see that the appendix is inflamed, that child is kept MPO, because surgery is just the only thing you can do for the child. You cannot give, like, put a warm compress and say, okay, yeah, you have it, let's put a warm compress. Because if you put it that warm compress, you are kind of hastening the rupture of that AP in here. You will also, in some cases, before they make their diagnosis, before the diagnosis is definitive, they do not give pain medication because we do not want to mask what is going on. Okay? Because they don't know, they want to know what is going on. Because once that child that is having this severe abdominal pain and all of a sudden says to you, oh, I feel some relief, you better call surgery start because that AP has ruptured. Okay, so that's one of the reasons that before they make that definitive diagnosis, they will not give pain medication because they want to know what they're dealing with. Okay, so once the child, says to you, oh, I feel better, that child is in danger because the inflamed appendix have ruptured and all the contents of it now seep into the peritoneum. Okay? And that child, instead of that child spending maybe 1 or 2 days in the hospital for just plain old simple appendix removal, the child is staying days and sometimes weeks in the hospital because they have to deal with giving broad spectrum antibiotics to clean that peritoneum. Okay? Usually the prognosis is very good if it's caught on time and it's just a tiny incision that they put and the patient do well. Again, you will have to teach all your post-op care, including using inserting parameter and early ambulation and all that you have to put in place for that patient. Okay. Any questions?
Yeah. If the appendix, let's say it's inflamed and stuff, they won't remove it, they just won't they won't remove it, because usually whenever we do
Removal is just all that is treatment.
I thought you just said that they just put a knot in it.
No. What I said is they just put a small stitch in a small incision and get the appendix out. Oh no. Surgical treatment is just the treatment. It's just the treatment. You want to take it out. Because if you leave it there, it will rupture. Okay.
You might get answer for what is the reason, what is the function of appendix in the body?
Just, yeah, God put it there for some reason, just to be there to collect.
Usually, yeah, it just collects the.
Yeah, it just collect, yeah. Non-function. That's why when you take it out, you don't really miss anything. Yeah. Any? Yes.
Does the warm compress, is that an old method to treat it until the headaches come out?
No.
I mean, just with the pain part of it.
Well, you do not use it. It's contraindicated. One compress is contraindicated because why is like some people would have abdominal discomfort and they'll say, oh yeah, let me put some warm compress in it, or they have something in there, oh let me put warm compress on it, it feels good. Warm compress in AP, in abdominal pain, until you rule out AP, warm compress is contraindicated. You cannot use it until you rule out AP. Okay? It's a contraindication. Don't use it. Because if you're using it now, you are warming the AP and say, okay, you know what, body, go there again. Okay. So, this one is another condition that would release AP, but it is a abnormal formation in the ileum. The difference with between this and AP is that this will present with abdominal pain also, but this will have rectal bleeding, and the patient can become anemic depending on how much the blood is lost. Okay, so with the abdominal pain, you have to rule out Michael diverticulum. But how you can tell it's not AP is that if you see that rectal bleeding as well. Okay, they'll do the same X-rays and scan. But in addition to that, they're taking stool to look at stool upward blood. There will not be any blood in the stool in AP, but in this there will be. And the management is the same, surgery is the same management for both of them. And then all the configurations for nothing here is the same. Okay. H-pump disease, on the other hand, is for some reason there is no nerve tissue in the colon, some loop of the colon, and that's called the aganglionic megacolon. And with that, you know, peristalsis will move with nerve. There is nerve tissue in their intestine, and that will help to propel the food and to activate the peristalsis. For some reason, one section of the colon has no nerve tissue, and what happens is that the peristalsis will come, will churn its way, churn. When it gets to that area that has no nerve tissue, it will stop. And then every other thing is just packing up there. So now it's like you have a clogged drain that is clogged here and nothing goes distant to that. And over time, that area of the gut that have no nerve tissue will have obstruction there. You know, it will swell, there is obstruction. So the patient will complain of pain. It can happen in children, and there is also a form of this in adults. For some reason, they have some part of the colon that is not functional. Okay, but you see it more in males and some kids with Down syndrome. So this is what it looks like, when there is. So this part of the all here is normal, and then it comes here, there is no nerve tissue, everything is backing up, and you see here nothing is going past this area because it cannot. There is no peristalsis here, everything is backing up here. So again, we do X-ray and we can do a barium enema. And they can measure the pressure in their rectum to see if there is anything. And they can do the biopsy under interventional radiology. They will take a biopsy of the rectum and then confirm the diagnosis. So once that is confirmed, well, we know that this area of the gut colon is not functional and it serves no purpose there, so we have to take it out. So usually they'll do a two-step procedure. The first one would be to cut off the area that is non-functional, put a loop at colostomy. It will be a temporary colostomy. And then when the area heals very well, they'll go back and do a revision and join the ends together. So it will be a two-way process. So for us taking care of this patient, we have to see this with the parents care of the colostomy. We would like to make sure that that stoma is nice and pink and that we don't have, the skin around the stoma is intact. Okay. So we would like to do all that for that patient, and we would like to also for the older, take care of that child. So biliary atresia, for some reason, it's an inflammatory process of that hepatic bile duct. It gets into fibrosis. And of course, it can cause some liver failure. And when that happens, there is not, the duct is not functional, there is nothing there, and our only choice, possible treatment will be a liver transplant for the patient. So how does that manifest when we see that there is that atresia? We know about our newborn jaundice, and we know the physiologic jaundice will just abate by the first 1 or 2 days, 3 or 5, when the person under the light will clear up. Because of immaturity, they are not able to handle the rate of breakdown of red blood cells. Okay. So that this one will be jaundice that will persist beyond 2 weeks of life. So the urine is very dark. Because the stool has no bile in it, it's very clear color, very light color. The liver functional enzymes, they're all very high. We have high bilirubin. The liver is not functioning. The prothrombin time is affected also. And what is the function of the prothrombin? Okay. So because the prothrombin is affected, that child will bruise easily. Okay, so you start seeing black and blue in a child, and before we call it child abuse, we just have to rule out all the conditions. Okay, because of that bile salt under the skin, bilirubin is very high. The child can itch, and by slow itching, they're also itching and breaking up the skin. So now you have to make sure that you maintain skin integrity. Child is not digesting their food because there is no enzyme, really. So they have failure to thrive, and their abdomen is very distended, and the result is that right. Again, besides our transplant, which is the ultimate thing, they can do a procedure just to modify to kind of create a drainage for that bile, at least to attempt to maintain the liver function. But again, most of it is like depending on how severe it is. So again, we have to support this child somehow. And what do? We have to give TPN, total parental nutrition, and this could necessitate inserting a central line. In pediatrics, we love the Brovia catheter. They can put the Brovia, or they put a Portacat on the patient. It's a form of the central line. They will use that. And because it's a central line and because it's a long-term something, the mom have to know how to take care of that. And part of it, they have to maintain a sterile technique for that. Because our liver is affected, We need replacement of vitamin A, D, and A, D, E, K. Okay? And then we have to put our bleeding precautions in place because already we said that the protein is affected, so this child can bruise, can bleed easily. So we have to make sure that we do all that, and we have to give support nutritionally and also do whatever we can to promote activity to our age and for developmental milestones that we let the child achieve. This, we saw this yesterday, clearly. Okay, it's just malformation of the face. We have that symptom. And this is going to be something that you will see. You can see that here, all this occur in utero. It will be cleft and palate. It will be just the lip to occur in the palate also. And all and on the facial features in the lip, the parents see that and start to be like, oh, sorry, but it's not normal for you to have that. But the aim would be to correct that, the lip, to close that deformity as early as 10 weeks of age, and if the child is able to weigh up to 10 pounds. In addition to not having any form of infection, like the child we saw yesterday, they cannot do that repair because the child is 22 days old, number one. Number two, the child has infection. So they have to clear the infection first, and they have to allow the child to grow for them to do the repair. Okay? So, but after they do the repair, usually, it's fine. The plastic surgeons, the usual technique now they're really better and better. The older you see some adults, they have it done years back. You see they still have some scar tissue on that, but the way they do it, you can hardly tell the problem. Okay. On the other hand, if the child has a palate, cleft palate, usually they will not refer that they'll wait for 12 months to 18 months before they can do the repair of the palate. Again, you think of that child that needs to develop language, speech and language, and by 12 months, that's the time they're starting to kind of, we want them to start, so they would like to repair that well so that the child will be able to develop. Otherwise, if they don't, then that will impact on their speech. Okay. So, this is my picture of this guy, and this is one to repair. Some of the issues, we have so many issues with them, feeding wise, and they can be fed, they can be breastfed, they can be bottle fed, but we just have to teach parents how to do that, and we have to encourage the mom. If she wants to breastfeed, encourage her to breastfeed. In fact, we can also, as part of the encouragement, if we have pictures of other kids that have had cleft palate repair, we can show it to them to see that yes, it is possible. Yes, your child lives this way, but when they grow older and repair as your child will look like it, at least that will give them some hope. Okay? That's happening. Other things that will happen is post-operative for this child immediately after the repair. We would like to prevent the child from sucking their tongue or putting their hand or anything in their mouth. So we may have to put like elbow restraint or mittens on the child. And remember, when you have a restraint on anybody, you better check that circulation and sensation of the extremities and make sure you release it. cleaned every 2 hours or sooner. Okay? And for this child, you hold the child, you'll be able to put the child's hand behind you or hold your hand so that she wouldn't, and just give the child some playtime away from middens, away from elbow return until that suture is healed. Again, we have to clean the suture line also with sterile water. And if the physician ordered the A&D ointment or any form of ointment whatsoever, then they did order, then we have to put it on it. So just make sure that that suture line is not infected. So after each feeding, we just rinse it. Okay? Now this is another structural deformity that you will see in the immediate newborn period. What you will notice is that the esophagus and there is no continuous passage from the esophagus into the stomach, so there is a blinding. So one thing you will notice is that if they are having as part of the immediate newborn assessment to put an NG tube on the patient, then you notice that the NG tube is coiling in the mouth or not even going any further. I know St. Barnabas Medical Center, they changed their policy like years back to include insertion of NG tube or as part of their newborn assessment because they had they missed one of these, so it's important that you notice it. So if the facility where you are have that policy, then they need to follow it. But anyway, what you will notice initially is that the child will there is excessive salivation. Child is, drooling a lot, and because of that, there is increased risk of that aspiration that will go with respiratory distress, especially after feeding, because the whole feeding is just in the pouch. So for this, once this is noticed, it is considered an emergency, and the child needs to be prepared for. The child should be put NPO, IV fluid, but nothing by mouth. Post-operatively, because they're still waiting for that thing to heal, they're not going to be feeding the patient, so they'll have to use parental nutrition via their central line. And then again, we would like to maintain our airway and prevent aspiration in the 10 years, of course, these are all possibilities of things that can happen. Okay, and this one, with the repair, they have to do a colostomy also until the anal opening of the throat is closed, so you have to do colostomy for 7 days. This one is another one that we need. We do here. The first one is gastroesophageal reflux after the cardiac sphincter, but this one will affect the pyloric sphincter, the sphincter that separates the stomach with the duodenum. Okay, so once it is affected, normally the food will get into the stomach and then will pass through the duodenum. But because there is an obstruction, the food is sitting in the stomach and the child will hang the stomach. This particular food did not make it into the duodenum, therefore there is no bile. There is no contact with bile because the food is not going into the duodenum. Unlike the gastroesophageal reflux, the food went into the stomach, some managed to go past the pyloric sphincter and found its way into the duodenum. But because of that weakness or laxity of that sphincter, you have the infection. So The vomit that you see in gastric esophageal reflux will contain bile but not the particular one. So again, surgery is treatment, and you have to let me just finish this one and then like this. Yeah. So easy perception is another one. Here there is when we talked about the headstone disease, we said that it is congenital in the sense that some of the some loop in the colon had no nerve tissue, and because of that there is that obstruction. This one, the whole GI tract is very normal, there is no problem. However, for some reason, one part of the colon will slip into the other and come into a blood. And when that happens, once it slips in there, it's painful and it can cause obstruction. Last semester, as old as I am, I had this situation I didn't believe it. Yeah. So for some reason, I don't know, I think it is, and I had to appreciate what this is in itself when they have it done. It was very painful. And there was complete obstruction. And very good. Whereas when I mean pain, it's like 200 So for our child, the child will be playing normally, and then all of a sudden they will scream and draw their leg next to their chest, because at that time that means the baby sleeping. Sometimes, and you will see it on X-ray on ultrasound, because this caption will see it also. But the X-ray, what I found in my own case, the plain X-ray showed a shade of something going on, but it wasn't conclusive until they did the CAT scan. Until I drank the contract to do the CAT scan, and then we saw that everything, up to that, up to the area they had it that the loop went in, there was no dye, there was no contract beyond those points. And that's how they were able to kind of figure out what was going on. But anyway, so once it's identified, value enema can correct it, can use to put it out. For my case, they use the NGP to suction. I had that for me 10 days before it was able to correct. Simply because there was no change in the chemistry or the, that said there was gangrene from it. But if that loop, it's a tight loop and there is possibility that gangrene of that intestine is occurring, surgical removal is just the only option because you need to release that. Otherwise, the loop that went in will stay here because now there is sort of a blood supply. And that loop can decay. And with that, you're sending toxin into the spring and then you're just going to kill it. Yeah. So it is so again, we do the post-operative care of this patient, but note that this is the GI is normal, but for some reason it's in, and that's what the patient will complain about. Okay. So the last one I want to look at in the GI will be the celiac disease, and that will be when for some reason there is absence of the child cannot digest the gluten. That's the last one. The The child cannot digest anything that contains gluten, and because of that, foods like anything that contains wheat, rye, all those child cannot digest it because when you right, white they can have rice. Rice is what they can have. They cannot have. So, with that, because they cannot digest it, now they have fat in their food. They have malnutrition. Their abdomen is distended. In addition to lacking of food vitamins. Again, the most important thing with celiac disease is that nutritional consult. You have to teach the family to read labels. They have to read labels. They have to avoid anything that contains gluten because that would not be good for the patient. Okay, so that's what we need. So I will stop here. Just let's take a break.